Thank you. It's a pleasure being here, and great to join your session with such distinguished faculty. I've been enjoying the talks that have been done so far, so look forward to interacting with you all. So my talk is pre-recorded, Dr. Anirban. So I'd like it to be displayed. Everybody, my keynote lecture today is on orbital oncology. What we know is around 20% of orbital pathology is orbital tumors, and of these, around 50% can be malignant. Orbital tumors can be primary, as shown in the left-hand side image, a patient with a primary orbital melanoma from oculodermal melanocytosis, can be secondary, as in spread from surrounding structures, as in this patient with a maxillary myxoma spreading to the orbit, or metastatic, as in the right-hand side picture, a patient with a neuroendocrine metastatic deposit to the right orbit. Now, the orbit is called a Pandora's box, and for good reason. It has so many critical structures, and you could get an oncological problem in any of these structures, and it's important to really be aware of the anatomy of the orbit thoroughly. In 10 minutes, it's going to be difficult to go through a large chunk of orbital oncology. Hence, I'm going to base my talk on these 5 practice points. I always tell my fellows that you need a high index of suspicion, a really thorough assessment of not just the eye, but looking at the interplay between the eye, face, and the orbit, examining the orbital rim, looking for numbness, cranial nerves, and the whole face will really help you come to a sort of a clinical diagnosis about orbital tumors. In example, patient was thought to have periocular cellulitis, but clearly the right side of the face is swollen, right angle is drooped down, and you get him to open his mouth, you see a lesion. This patient actually has a maxillary squamous cell carcinoma. Another example that globe dystopia need not only just be proptosis, you've got to look for horizontal as well as vertical movement. This patient has a maxillary tumor which is pushing the globe outwards. Patient has a superolateral dermoid which is then pushing the eye forwards as well as downwards and inwards. A simple torch ruler is enough to look for globe dystopia, and for exophthalmometry, I use a Hertel's exophthalmometer as well as examining the patient from the side as from the top. The second point is about scans. Now, orbital tumors is a clinical radiological diagnosis. Just by clinically taking a guesstimate, you're often wrong 50% of the time, and the radiology is really important. Now, depends on my clinically suspected etiology, I would consider the scan. This patient has a lesion in the right orbit, which is around the bone, hence a CT scan was done, shows a bony erosion, bony destruction really, and clearly confirms the metastatic lesion. Patients with soft tissue lesions just need a MRI, like this patient with hemangioma. And in some patients, you need both a CT and MRI to look for bony changes as well as soft tissue tumors characteristics. I still perform ultrasounds in certain patients with orbital tumors, as in this child, where the lymphangioma can easily be identified on ultrasound, and the MRI confirms the same. Really helps in giving early diagnosis and making a management plan, and it's an easily available tool worth keeping in your clinic and making use of. Third point is about biopsies. So not all tumors need biopsies, such as a hemangioma. Some tumors need excisional biopsies, such as pleomorphic adenoma, and some tumors, such as a lymphoma, which just need an incisional biopsy. I'm going to spend a quick minute on CT-guided biopsies. We've started doing a number of these in Sheffield, and what we find is that, let's imagine a patient has suspected metastasis. We do a CT scan anyway quickly, and what we would do at this time is give a peribulbar, retrobulbar incision. Scan is done, and then a temno needle is used to get a core biopsy of the lesion in the same sitting. And lots of advantages. I mean, we get good histopathological sample for diagnosis as in these patients, but importantly, surgery is avoided. There's no general anesthetic, day case procedure. And in these patients with suspected metastasis, there's no incision, hence there's no need to await healing before you start treatment. So you can really commence treatment pretty quickly. And especially in this COVID era, it's really helpful. So quite worthwhile considering if it's possible to do CT-guided biopsies in these group of patients. Fourth practice point is about surgical approach. Now, depending on the location of the tumor, I base my incision. So let's imagine a laterally located tumor. If it's extracorneal anterior, just a lateral canthotomy is enough. If it's extracorneal posterior, a upper lid skin crease incision could be enough. But for patients who have an intracorneal tumor, I often use a S-shaped subbrow incision. Gives me good access to the lateral orbit. A medially located tumor, I would use a retrocurricular incision, and a inferiorly located tumor, I would do a lower lid swing. Upper or superiorly located tumor are really difficult to biopsy, and I'll come back to that as my fifth practice point. This is a patient who is losing vision in his right eye with proptosis, secondary to a unusual lesion which is wrapped around the right optic nerve. S-shaped subbrow incision is done. As the tumor is laterally located, gives lateral good exposure of the lateral wall really, and lateral orbitotomy is performed. I've done this in the navigation system, as I find it quite useful to separate the tumor from critical structures. Lateral rectus is hooked and the tumor is removed, bones put back through, and the surgical site heals quite beautifully, giving us excellent cosmetic results. This is an example of an inferomedially located tumor, which is compressing the optic nerve at the orbital apex. I've done a retrocurricular incision, but extended it in the lower lid swing area, and gives me good exposure to be able to remove the tumor completely. But what about superiorly located tumor? I've tried a open, like a upper lid split incision, which really hasn't given me the results I wanted. Hence, I've come up with this really novel technique, and I really hope you find this useful in your practice as well. I've labeled it the Salvis W incision, and the reason I've called it a W, it's a bit of a poetic license, but if you imagine the left eye and the incision there, you make the first incision at 10 o'clock, peritomy, second incision is at 2 o'clock. The third limb of the W is parallel to the lacrimal ductules, and the fourth limb is a superior cantholysis. And I'll give you an example. Here's a patient with a left superior mass under the left superior rectus. And here's a video of me doing this W incision. I'll fast forward it for time reasons, but you can see how the W is created. I often put a bit of bipolar at the second and third limb junction, as it allows me to orient the tissues at the end when suturing. The conjunctiva is cut along the lacrimal ductules and superior cantholysis is completed. And what I find is, it's very easy to detach the superior rectus after this incision. The lid opens like a book, really. Easy to hook the superior oblique, and really gives beautiful exposure to the superior orbit for me to do a biopsy or removal of tumor as necessary. It's quite easy to put the conjunctiva back and close the lateral canthotomy, superior cantholysis incision pretty quickly. And it does give really good cosmetic results. The conjunctiva heals very well. This patient's done very well following this surgery. Another example, we talked about the four limbs of the W. You often, if the tumor is small anterior, you need not do the fourth cut of the W. So the fourth limb need not be done. And that's what I call as a modified Salvis W, really. Just some nice photographs showing this patient with a superiorly located tumor again, where the conjunctival peritomy is completed, a subtenons is given, superior rectus is hooked and detached, and with a cryoprobe, the tumor under the superior rectus is removed, and the conjunctiva is put back with excellent cosmetic result after this surgery and complete resolution of the tumor. So in the last 10 minutes, I've talked about 5 practice points. I do hope you've liked the idea of the W incision. As orbital surgeons, and many of my colleagues have mentioned that really been difficult to find the perfect way of getting a biopsy or removing superior orbital tumors. And I really hope we can make more use of this W incision to help patients with this tumor in this location. So thank you very much to Fairuz, to Partha, and everyone at All India Ophthalmic Society for giving me the opportunity to talk today. All the best.